Welcome back. My name is Dr. Natalie Cruitt, and this is the third lecture in our series looking at physiologically guided or targeted CPR and how we can better understand the physiological conditions the heart needs in order to get it restarted again. Now, we've already gone through a few of the goals of care that we try and achieve during cardiac arrest resuscitation. Let's move on to another goal now, which is perfusion pressure. We want to be able to achieve an adequate coronary perfusion pressure, and that's because myocardial blood flow is a major determinant of resuscitation success. Now, this is probably common sense and a pretty basic principle. What we're trying to do is deliver enough blood flow, oxygenated blood, to the coronary arteries to get that heart muscle restarted again. With our CPR and with our adrenaline administration. But how do we know what that coronary perfusion pressure is? How do we know if we're actually achieving enough blood flow for that patient in order to get that heart muscle working? Now, diastolic pressure has been endorsed as a surrogate marker for that coronary perfusion pressure. What exactly do I mean by this? So we know that the coronary arteries receive their blood supply during diastole. The coronary perfusion pressure is the driving pressure between the aortic root, where the coronary arteries originate, and obviously that pressure is going to be high, and the pressure that is present in the chambers of the heart. That pressure is going to be lower than the aortic root pressure. And that pressure difference, the difference of high pressure to low pressure, is what drives the blood flow through the coronary arteries and into the myocardium. Now, being able to measure this during cardiac arrest is technically challenging and it's not practical. So instead, people have researched and evaluated diastolic pressure as being a potential useful marker for coronary perfusion. And what they've found is that it's a reasonable surrogate. So if we look at our diastolic pressure when we're resuscitating a patient, we have a reasonable indication of what is happening in the coronary arteries at the time. Let's not forget that the heart is a perfusion princess. And in order to get a ROSC, the myocardium requires the delivery of oxygenated blood under pressure. This is becoming a theme of these lectures. Now, the pressure part becomes even more relevant in the setting of cardiac arrest when you have a patient who has arrested due to a coronary occlusion. This picture on the slide demonstrates a blocked coronary artery, and you can see the narrow area available for blood to flow. Now, in order for the myocardium to be perfused, that blood is going to have to be delivered under a significant amount of pressure in order to pass the blockage. So we want to try and aim for a diastolic perfusion pressure, or a diastolic pressure, I should say, of greater than 30, but ideally, the evidence is now saying that we probably want it closer to 40. Now, there's a reasonable body of evidence that says that a diastolic pressure more than 30 is associated with ROSC. What that evidence doesn't really tell us, though, is whether the increased diastolic pressure is an association with the ROSC, so it's a predictor of having a good outcome, or if it's the cause of the patient going into ROSC. And I suspect it's probably a bit of both. We definitely know that if you achieve a higher diastolic pressure, particularly in the early phases of the cardiac arrest, your chances of getting a ROSC are significantly increased. I just want to show you this video here of how it is actually possible during a resuscitation to hit those normal physiological targets. Here we have a patient who is completely arrested. They're being paced. They have a Lucas ongoing. We've got an invasive arterial blood pressure line in situ. We are achieving an invasive blood pressure of 108/40, and we're even achieving a non-invasive blood pressure, indicating that there's some degree of pulsatility, particularly in the brachial artery. Now, if we look at the patient and we tailor our resuscitation and our endpoints to that individual, it is absolutely possible to achieve those physiological endpoints that you're seeing on the screen. So, what does all of this mean for your practice in the real world in the pre hospital space? What are you doing with this coronary perfusion pressure or diastolic blood pressure target when you don't have femoral arterial lines in or invasive pressure and your non invasive blood pressure would be unreliable in the setting of cardiac arrest? How does this actually translate to you? I guess the biggest message I want you to take home is that adrenaline should not be de emphasized. In fact, ILCOR strengthened its recommendation for the use of adrenaline after the Paramedic 2 trial. We know the Paramedic 2 trial caused a lot of confusion among people who were willing to actually de emphasize or not give adrenaline because they thought that it was associated with a poor neurological outcome. Now, the large scale RCTs have demonstrated that adrenaline is associated with a higher ROSC rate in the pre hospital setting. That part isn't in dispute. What they have not demonstrated, though, is survival to good neurological outcome. And why is that? It's because in these large randomized trials, the adrenaline was actually given late in the arrest, up to 20 minutes since the time of collapse. Now, I've told you today that we know that adrenaline administration does increase your chance of a ROSC, particularly when you give it early. So if you delay the administration, of course, you are going to have a worse neurological outcome. The longer the low flow, the more time there is that the brain is not being well perfused. And then what happens? You come along, you give adrenaline at the 20-minute, 25-minute mark, and boom, you get a ROSC, but you get a ROSC in a patient that hasn't really had good cerebral perfusion for the duration of the cardiac arrest. So it stands to reason that these patients wouldn't have a good neurological endpoint when they're assessing outcomes. But what the trials did very clearly demonstrate is that if you give adrenaline, you increase your chances of getting a ROSC. So it should be one of the first things administered when we're faced with a non-shockable rhythm. And just remember, as I said, the earlier the administration of adrenaline, the more association there is with getting a ROSC, which is why the time to adrenaline administration is measured as a KPI. Now, I've been banging on about it, but as I keep saying, that heart needs a coronary perfusion pressure to get a ROSC. And adrenaline is currently the only drug available in the pre hospital setting to get that pressure up. So, the key message here is don't delay adrenaline administration. Please don't de emphasize it. It needs to be an absolute priority in those non shockable rhythms. And in the shockable rhythms, in the shockable arrests, you want to deliver your first couple of shocks and then be giving your adrenaline, but you still do not want to be delaying it. Adrenaline is what you have available to you in order to perfuse that myocardium by providing pressure and oxygenated blood flow. And we know those factors will increase your chances of successful resuscitation outcome. Okay, I think I've covered that. And I think I've pretty much hammered the point home that adrenaline is important at the moment, whilst we have no other drug available to us in the pre hospital setting. Now, the whole theme of this lecture series is that physiology matters. We have to keep in mind what organ we are trying to impact. And in the case of defibrillation, it is the heart muscle. So let's turn our attention now towards defibrillation. When we're defibrillating a patient, the principles of individualized resuscitation and physiology still remain. We have to keep in mind the heart's orientation, where it sits in the chest, and the metabolic conditions that the heart muscle requires in order for it to contract. So the likelihood that defibrillation will terminate VF actually corresponds to a number of factors. That is the duration of the untreated VF, pad placement, so ensuring that the flow of current is directly through the largest area of cardiac muscle. I'm just going to say that again. You want to have correct placement so that your vector or the flow of current is directly through the largest area of cardiac muscle. The degree of coronary perfusion that the heart is receiving, yep, there's that term again. You will increase your chances of a successful defibrillation if the heart is seeing good coronary blood flow, which is why they get you to continue compressions for 2 minutes before you shock. And then we want to see, or we want the heart to have a certain amount of oxygen delivered under pressure to the coronary arteries. So oxygenated blood delivered to the heart will increase your chances of a successful defibrillation. It's no use defibrillating a patient that's hypoxic. A, they won't stay in a shockable rhythm for very long if they are hypoxic, but B, your shocks are probably not going to work. And finally, you want to look at the metabolic conditions that the patient's in. A severely acidotic heart won't respond well to electrical cardioversion or defibrillation. So the aim is to try and head the heart back to as normal physiological conditions as possible in order to maximize your chances of a successful cardioversion. You then want to make your first shock your best shock. As I said, the heart is a princess and it requires the direction of electricity it receives to be just right. Now, this is a great image generated by Michael Heller from Core Pulse. This picture demonstrates the energy flow that occurs during defibrillation and just how important it is to visualize where the heart is sitting in the chest and getting the pad placement correct. This image nicely demonstrates what we're actually trying to achieve with the electricity arc when we're placing the pads. And as I said before, the heart has to sit in the middle of that electrical field. So you want the largest amount of myocardium to be right in the center of that electrical field. Now, the right, or the sternal pad is placed to the right of the sternum, below the clavicle. The apical pad is placed in the left mid-axillary line, approximately at the level where you would place your V6 ECG electrode. Importantly, the pad position, particularly of that axillary pad, should be clear of any breast tissue, and it's important that the pad is significantly lateral. And in practical terms, really, you want to aim for the pad to be placed just below the armpit. Too often we turn up and we see that lateral pad or is placed sitting on the towards the stomach, or it's sitting just below the nipple line. That isn't going to provide you with a good vector of electricity or a nice arc that we saw in the last picture. So I really want you to pay attention to detail. I want you to pay attention to where the pads are being placed. If you look at the picture on the screen, you can see the heart sitting there and that axillary pad placed just underneath the armpit, providing that nice straight line through that largest area of myocardium and a good vector. We know that sternal pad is easy to place. It's 9 times out of 10 placed correctly. However, research has shown that a lot of the time, that lateral pad, as I've been saying, that is meant to be aiming for the apex of the heart, hasn't been shown to be well positioned at all. I don't know why, but people just aren't, I guess, in the heat of the moment, able to place that pad in a good anatomical position. That pad is probably going to be quite important in establishing that successful vector for cardioversion. So from here on, I really want you to pay attention to that detail and ensuring that auxiliary pad is placed right underneath that armpit. It's not just up to the first crews attending to get that pad placement correct. Now, while we want them to be able to do that and we want them to be able to get pad placement right the first time to make your first shock your last shock, in the heat of the moment, as the first crew on scene, the pad placement may not be as optimal. So it really is up to the second crew as well to be vigilant and to build into their workflow, checking the pad placement when they arrive on scene. Just as important as it is to check that there's an adequate airway and that the patient is oxygenating and ventilating and that CPR is effective and that you don't need to change operators, you should build into that workflow, is the pad placement correct? Now, if you have delivered multiple shocks and are not achieving a ROSC, check your pad placement. Build that into your workflow as one of the differentials as to why the patient remains in cardiac arrest. Now, we talk about dual sequential defibrillation and stack shocks. And yes, I think there may be some evidence for that further down the track potentially, but I think what we're finding is this: the majority of the time, those pads aren't placed in the correct position and the position that will actually provide you with the best vector for those heart muscles to then cardiovert. So take a beat, get the pads right the first time with good contact, and just make sure that your first shock is going to be your last one, or at least, I should say, set yourself up for success. Ensure that the patient is being oxygenated. Ensure that adequate CPR has been occurring and that you're giving that initial 2 minutes of CPR before you throw away that shock. Deliver that shock with pads that are placed meticulously well with a good vector traveling between the largest part of the myocardium. And hopefully, that first shock is going to be your last one.